Hi, good afternoon. Woo. Thank you so much for having me here. I'm delighted to be here, absolutely delighted to be here to talk about innovation and evidence in wound care. So let me just get to grips with the clicker. Make sure it's my friend. All right, sorted. So today I want to talk about innovation, and I want to think about innovation and its links with evidence and also with implementation. So this is something that we could talk about across the whole healthcare sector, but obviously today I want to think about it specifically around wound care, thinking about wound care. So we're going to talk about some examples, and I'm going to think about some of the issues and raise some questions. So just to give a little overview of what I'm going to go through in the talk, I'm going to think about defining what innovation is. Think about this kind of triangle of three elements that I'm going to talk about around innovation, around evidence, and around implementation. Think about challenges and think about where we may go from here in the future with relation to some of these issues. Okay, so the first thing I wanted to do was think about defining innovation. So you go, have a look, and there are loads of different definitions of what innovation is when it's considered in the context of healthcare. So here, there are just some examples of some of the wording that I found. So I think, and I hope this is fairly uncontroversial, that there are some key underlying themes that we mean when we say innovation or something is innovative. Largely we're looking at things that are new. We're looking at new activity over and above what's already done, often aiming to achieve some benefit. And I think more implicit, certainly not mentioned in any of these definitions, is that innovation often involves change. So we talk about change, especially in healthcare sectors a lot, and we talk about innovation, but we don't necessarily talk about them together. But often innovation is something that's new, and so that requires change. And for me, that makes me think about innovation in a slightly different way. So, given that this talk is about innovation in relation to wound care, I just want to think about the types of innovation. So quite often when we use the term, so something new that's happening, something that we're changing, ideally to achieve some kind of benefit, we're often thinking about drugs or devices, things that we use, and new things that we start to use. But innovation as a term is much broader than that, and we can use it to describe any new activity that we're doing. So this might include new digital technology. It might be how services are delivered, so changes to the construction of teams, how care pathways are structured. I've mentioned technologies, practices, and also policies. So the term has a broad application when we're thinking about how it's used in healthcare. So, and this might seem, just going to get some water. This might seem like a kind of an obvious point, but why is innovation important? Why is it something that we're focusing on? And so, if you think, arguably, it's probably only in about the last 150 years where having some contact with a health professional was more likely to help you than kill you. So for centuries, medicine wasn't necessarily a scientific discipline, and it's in recent years that it's become something positive for patients. And a lot of that, or all of that, is because of innovation, increasing our understanding of how the body works and how we try and help it. So antibiotics, vaccines, diagnostic machines and processes, these are all innovations that have been hugely beneficial to medicine. Obviously massively important are prevention activities, so quite often innovations are simple things that are hard to implement, for example hand washing, improving hand hygiene. So these are all really important innovation, and this, it hasn't come out properly, this is a copy of the NHS long-term plan, and obviously innovation is central to that, and the terminology is used a lot. So I would suggest that innovation is quite a human trait. It's quite a human thing to want to improve things, make things better, to change things, to look at a problem and try and find a solution. We kind of do that naturally, and I think we then see that in healthcare. But we also have to guard against our urge to innovate or be aware of potential implications of it. So this is where I want to bring in talking about innovation. So we've talked a little bit about innovation, and I want to think now about evidence, because I would suggest that innovation is often mistakenly viewed as being positive, so that something new is always going to be better. And I don't think that's true. And that's where I think evidence and use of evidence, and I use evidence in a very broad context here, and I'll talk about that in a moment. But I think that it's reasonable in a healthcare setting to think about whenever we're going to change something, so we're going to put in an innovation, to think about why we're doing this. What's the need for that innovation? What's driving our decision to do this? And then to have some proof that the change that we're making, that the innovation that we're implementing is safe, that it works. And when I talk about evidence, as I'm saying, so I lead the wounds research unit at the University of Manchester, and I used to work at the University of York, and I work with Nikki Cullum, and so we've got a long history of doing randomised controlled trials. And I love a randomised controlled trial and I love a systematic review, but those are not the only type of research, far from it, that's important in any area of health. Trials answer a specific question, and there is no way that we've got the time, money, or motivation even, to do trials to answer every question around wound care. We need to draw on evidence that covers a spectrum of different methodologies. That might be, we need to use real-world evidence, and we need to draw on sometimes rapid assessments. But it's really important that whatever evidence we're using, we acknowledge the strengths and the weaknesses of that approach. There are some approaches that are just not going to be able to answer the questions that we want to. As decision makers, I always kind of imagine that people are working in a bubble of uncertainty. Whenever you make a decision, you might be unsure about what's going to happen. There's a lot of uncertainty, and the idea of evidence is that it kind of reduces that uncertainty. It can never remove it completely, but hopefully it shrinks it. And the role of evidence is to affect that uncertainty. It can be bidirectional, it can add to it, or it can take it away. But we need to be clear that whatever evidence we're using, issues around bias, around chance findings, and around confounding need to be considered. So we're making kind of we have realistic expectations of what evidence is going to tell us. So going back to the point about why uptake of innovations that potentially don't work needs to be considered. And it's for all the reasons that you would think about. If we start using potentially unproven innovations, then there are potential risks. They might not do what we think they're going to, and they might be unsafe. Slightly more subtly, there could be opportunity cost. So if we start pushing budget in one direction, we steer it away from another activity that may have actually conferred more benefit. Because the NHS budget is constrained, there's always an opportunity cost. Whatever you're doing, you could be doing something else with your time or with products that you use. And so we need to think really carefully about whether change to something new is not incurring an opportunity cost. And closely related is the idea of displacement. So when you start doing some activity, some new activity, what isn't being done that may have actually been a better activity to do. And also, when innovation starts being used in practice, it actually makes it really hard to research. Ideally, what you do is you do the research, then you'd find out whether something worked, whether there was going to be some kind of net benefit, and then it would get used in practice. Often things don't happen in that order, and if there's strong uptake of innovation in the absence of research evidence, then getting that research evidence can be challenging. So I just want to start thinking now about some examples in wound care. Specifically, I'm going to be thinking about some devices, some innovations, just to kind of look at some patterns of things that happened and to think a little bit about the questions about was there unmet need and what do we know about these innovations. So this, I haven't got a laser thing, so I'm going to point. So just to kind of orient you to this graph. So this graph is presenting prescribing data from England in the community. It details silver, which is the blue line, honey, iodine, and other antimicrobial dressings. So for ease, it's probably worth just looking at the blue line, which is the silver dressing, and time runs along the bottom. So from this graph, if we just look at the blue line, silver dressings became available, or certainly prescribing data was available in about 97. You can see in about the year 2000, between 2000 and 2005, there was a massive increase in the quantity of silver dressings that were used. So this graph is the same data, but instead of quantity used, this is the cost, the expenditure data that we've been able to get. So from 97, when there was almost zero expenditure, to 2009, when there was the highest expenditure, it's an increase of £0 up to 26 million, so for England community. So this was an innovation that saw some pretty rapid use in England in the community, presumably for treatment of wounds. And it's just really interesting, I think, to look at this and ask those two questions. Do we need this? Presumably we do. It's used a lot in practice. And what's the level of uncertainty around the benefit that we're getting from these treatments? And the need is really interesting because these dressings are used on obviously wounds that may be at risk of infection or be slow to heal because of some concerns around infection risk or bacterial load. It's difficult to get actual data on the relationship between those clinical parameters and healing, and it's difficult to get data on the evidence of the effectiveness, both clinically and cost effectively, for these dressings. It's not that they don't work, it's more that we don't know because we haven't collected those data in a way that helps us answer the question. So we're operating in a kind of, with this innovation, it feels like an area of uncertainty, certainly from a research perspective. So we saw this increase. We know there's a lack of evidence. So it's interesting to start thinking about this in the context of, have there been opportunity costs? Is there being displaced activity? What are the outcomes? What's the benefits? So I just want to think about another example, again, thinking about innovation in the context of evidence. So for now, I want to focus on protease, assessing protease activity and the use of protease modulating dressings. So there is a test, I don't know if it's still available, but a test that you could do to look at protease levels in wounds. Obviously, the underlying science behind this is it's suggested that high levels of protease, you need proteases as part of the healing process. If the protease levels are too high, it actually impedes wound healing. If you regulate protease activity, you're going to have benefit on healing outcomes. So, and there was a test available that preceded the use of the dressings. So you could swab a wound, it would tell you if there were high proteases. If there were, you use the protease modulating dressing and you would get improved patient outcomes. So we went to the literature. We went to randomised controlled trial literature in this case, because that's the ideal design to answer these kind of questions. And we said, okay, so use of test and then a dressing is a test and treat policy. It's like use a diagnostic test. It's like screening. You screen, you treat. What's the outcome? You do randomised controlled trials to answer those kind of questions, but we couldn't find any. And then we said, okay, well, what's the evidence for the dressings themselves? Is there any evidence from trials that they improve outcomes? And we found 12 trials, so there are data there. When you pull the data together, the trials are fairly small, so overall it's still unclear about whether there's any benefit. So what we did next was we did a different type of randomised controlled trial. So thinking about the first question that I've been asking, do we need this? What's the driver for this kind of innovation? We said, okay, well, there must be good evidence that high protease levels impede healing in wounds, because that's where all this came from. So we did what's called a prognosis review. So we wanted to look at different types of research now. The research that says these factors about patients, their age, their wound characteristics, whatever, are associated with outcomes. It's kind of like risk factor outcome research. In this case, the risk factor was high protease levels. And so we said, okay, well, there must be evidence of this science that's supporting the development of this. So we did this work. We found 13 cohort studies with about 500 people that had usable data. And the research is really poor quality. And there's a complete uncertainty as to whether, based on these data in people, so this is looking at human research, because of the types of analysis that have been done, whether high protease levels are associated with good or bad wound healing. So again, it's thinking about these questions. Do we need it? What do we know about it? With this innovation, again, it's not saying it doesn't work. It's just saying how much do we know and how much energy should we expend in different areas when we're thinking about change and changing practice. And again, just to use the example of negative pressure wound therapy. So this is, my title's Rise of the Machine, so I probably should have talked about machines a bit more. But this is another really interesting area where we're thinking about the use of negative pressure. It's quite hard to get usage data on how widely this is used, but I don't think it's controversial to say that it's probably used a lot more now than it was 10 years ago. It's something that is fairly common, and there's been a lot of change and innovation in terms of negative pressure, starting off as something that was mainly for open wounds to PICOs and other disposable devices that are used on closed incisions to prevent SSI, so a different kind of a different clinical objective to use in the treatment. So at the moment there are a lot of trials ongoing for negative pressure wound therapy, but there's no good trial evidence that it's effective. There's a lot of uncertainty around whether this is a clinically or cost-effective treatment based on trial data from the systematic reviews we've done. The HTA is funding a lot of trials in this area at the moment. So there's a lot of kind of public funding of trials. There's the Sunrise trial, which is looking at use of disposable negative pressure wound therapy for emergency laparotomy wounds. Wolf has just reported, that was a large study that's been published in JAMA, or the New England Journal of Medicine, on open fracture wounds, and that suggested that negative pressure wound therapy wasn't cost effective for those wounds. We're doing a trial of surgical wounds, healing by secondary intention, use of negative pressure on that. So there's a lot of ongoing work. But again, that research is arguably more challenging because these products are used a lot in practice, so we're kind of trying to catch up with the evidence. So there are examples of innovations in use where we're not necessarily able to answer the questions as well as we'd like to around what was the driver for using this in wounds, and what do we know about what we're getting back from it. And there's also limited use, so in drugs, the idea of using products only in research. So rather than drugs where there's uncertainty about the clinical cost effectiveness being rolled out on a wide scale, they can be used in the context of only in research. So they can be used, but only if they're being evaluated. And that's something that I'm not aware of happening as much or at all with the kind of devices I've been talking about today. So we could talk a whole different topic for this presentation. Could have been what kind of drives this rapid uptake of innovation when there's relative uncertainty from different angles about what the benefit is. And there's a whole load of different potential reasons for this, some of which are here, and there are other things that I've not even mentioned. What I want to just really briefly talk about is, just check the time, is this idea of an intervention paradox, because I've presented information on some devices where I'm kind of saying we're not sure, we're seeing quite a lot of use, so actually quite successful diffusion of products in the face of what we think is relative uncertainty. And there's a bit of a paradox with some other interventions in wound care, where there is actually really good evidence that there is some benefit to be gained from them. So the example here I want to talk about is compression for use of venous leg ulcers. So in Greater Manchester, we did a survey a few years ago to look at people with venous, well, we looked at all open wounds across the Greater Manchester area, and we did a kind of point prevalence study, and we also looked at what treatments people were getting. So this is data that's been pulled out for people with venous leg ulcers. So the blue line at the bottom is basically the proportion of people with a venous leg ulcer who were getting no compression, and each of the bars is a different area of the Greater Manchester and East Lancashire area, geographical area where we did the research. So you can see there's huge variation, starting with most people with a venous leg ulcer in one area getting compression to the other extreme in one area, where more than half of people were not on compression when they had a venous leg ulcer. So this is complex. I think if you think about certainly interventions on a sliding spectrum of being a simple intervention to being a complex intervention, compression is certainly up the scale in complexity to compare to something like a dressing. There's lots of different factors around the type of compression you use, and also a lot around patient adherence and how staff and patients interact, discuss and promote the use of compression. Again, we could talk about this a lot, but what I'm just going to focus on today is this. It's not very clear and I'm in the way, but these lines here are the number of people that were using 2-layer hosiery. And we were really interested in this because we did the Venus 4 trial, which I presented before, and found that compared to the 4-layer bandage, for people for whom 2-layer compression stockings, hosiery, who had a venous leg ulcer, for whom it was a suitable treatment, use of this treatment on average was cost effective. So if this treatment was offered to people who were eligible for it, it was cost saving overall to the NHS. So we saw these data and we were like, oh my God, we have so much to learn. So part of our job really is to try and implement what we research. And when you compare it to something like the use of silver dressing, that graph, ideally that's what we would have seen for this. My God, it works, it saves you money. And no one where we work was using it. Then we found out that for some of the sites it's not on formulary, loads of different barriers to the use of this treatment. And as I've said, compression is an interesting innovation to think about. It's been around for years. There's a lot of issues around training and complexity, and there's certainly a lot that we need to learn, and we recognise this. And that's where we started thinking about implementation. So this is the kind of third part of this kind of triangle that I've been thinking about around innovation, evidence and implementation. So some innovation seems to be rapidly adopted and diffused successfully. Some isn't. That's not news really. We're kind of aware of that. With the compression in Manchester, we've been doing something called the Illumine project, which is a quality improvement project to try and increase the use of compression, and also to reduce the time for some people getting Dopplers, which in some areas is seen as a bit of a pinch point to prevent compression use in some patients, and also to increase the use of 2-layer hosiery. So I'm not going to talk about that in detail, but more just to note that this is obviously really important, and especially for interventions that probably have a bit more of a barrier in terms of encouraging change. So I've talked loads about devices, and I said at the start of my talk that they're only one type of innovation. They're really interesting for various reasons, but there are other innovations that are massively prevalent, and there's a lot of focus on at the moment, especially in all areas, but including wounds. So I wanted to talk about digital innovation, and again, I think mainly to raise the point that these two questions that I started with, why do we need it, and will it help us, apply equally to this kind of technology. For example, and just plucked out of thin air pretty much, 3D cameras, lots of talk about it, really interesting. But those questions are really important. Why do we need them, and will they help us? They might, but we need to be kind of critical, because the time we spent thinking about 3D cameras could be spent on, I don't know, other kind of measuring infection with apps or whatever. But digital innovation is an interesting area because NICE has recently produced evidence standards, and these aren't that common for things that aren't drugs, certainly in the UK. So these are quite interesting because they say when you introduce digital innovation, this is the kind of evidence you should have before you think about using it. And it's probably still a work in progress, but it's an interesting concept that when you think about, for example, the device examples I've been talking about, you can see there might be potential benefit. So I then, last but definitely not least, wanted to think about service delivery very briefly, because this is a really important type of innovation, and some would argue that potentially this is the area where there's huge potential for patient benefit, which is changing the pathways through which patients receive their care, increased prevention, reducing time of assessment, all these kind of things. And I think this innovation happens a lot on the ground, but data aren't collected on it very well. And part of that, I think, is because of the massive barriers to getting access to routinely collected data in the community, because of obviously the really poor provision of IT that community care has at the moment, which is improving, but kind of accessing that data gives you an opportunity to think much more about measuring this kind of innovation. But I think it's really, really important, and it's really important not to lose sight of the value of it when we're thinking about potential devices that may or may not help. So I just want to kind of pull everything that I've been talking about together into what I've pulled it into, and I don't think this will be anything particularly new, is what I've called the innovation pathway. And again, I guess it's just questioning when we're exposed to innovation, thinking about, I put it as 4 different steps. One is the rationale for that innovation. So the theory, the supporting scientific evidence, the need and the value, why we're doing it. The innovation itself, how's it been developed? Has it been refined? Have users been involved? What is it? And how does it link to the rationale for its development? We need to think about evaluation and then also, as I've mentioned, implementation. So just to conclude with some summary points. So innovation is obviously really important. I don't think anyone would question that. And I think we can all recognise that innovation can be influenced by a lot of different factors. I think innovation should be based on need and also good science where that's sensible, or good rationale for investing time and money in the potential for change. Ideally, it should be supported by evidence or draw in ongoing evaluation where that's possible, and that we should caution against adopting new innovation at the expense of things that may actually give more benefit in the long run. So I think the the future actions are really closely linked to a lot of things that I've said. I think the idea of the production of evidence standards for devices is really interesting. So to give a bit more guidance about the kind of evidence that might be required for different types of innovation and different types of outcome, I think some kind of decision framework would be really useful. And I just want to end by putting this quote up, which is from the paper which I've cited, which I think is really true. I think, you know, innovation will always happen. We work in an environment that changes rapidly, but we don't want things to change so much that we are always moving forward without holding on to the things that offer benefit overall. So, and then finally, I just need to acknowledge the fact that a lot of the work that I've presented here today has been funded by the NHR through different streams, including the Biomedical Research Centre and Clark funding, and obviously has been conducted by a lot of people from the University of Manchester and other institutions. Thank you.